Hello, my name is Emily Betances. I'm the child life specialist here, and I'm going to go over some non-pharmacological pain management techniques. So these can be used for insulin injections, they can be used for finger sticks, pump changes, sensors, removing of adhesives, all those kinds of things, and anything else that other non-diabetic kids might need too. So starting off, let me see if I can get it to go to the next slide, maybe.
Just click on the actual slides and they should be
Great. Noted. All right, so one of the theories that a lot of these come from is called the gate control theory for pain. And basically that just means that the pain receptors, as the pain sensation moves from where you experience the pain to your spinal cord, we can sort of interrupt that by using a different type of sensation. So there are lots of different ways to do that. And Buzzy is one of the ways that we do. So Buzzy is a vibrating bee. It has the ice pack wings. You can use those, you cannot use those. But the idea is to put it in between wherever the pain is and in between the brain. So that might be above the arm, over where you're giving the injection. It might be on the hand, over where you're going to do a finger stick. It can be wherever you need it to be, but it vibrates pretty aggressively. And the idea is just that the movement caused by all the buzzing, the different temperature, it inhibits those neurons, closes the gate, and reduces that painful sensation that the kid might feel. So this is also a great way for the kid to be involved. So giving them their own role in their treatment can sort of help with compliance over time. It gives them more control and can reduce some of the pain they're feeling when they do have that control. The one thing is these are kind of expensive. So they're like $50 to $60 on Amazon, which is a lot. But you can essentially do the same thing with other things. So whether it's tapping above where you give the injection, or pinching, or using a cold pack above it, whatever that might be, you can sort of do the same thing with other things that are not so expensive. So this one is my favorite. It is called the shot blocker. And so it works in a similar way. It has dull, spiky things on it. And you push it on the skin around where you're doing the injection, or on your finger, wherever it might be. And the idea is that it just desensitizes that area to any kind of pokes. So again, this is a great way for the kid to be involved. They can hold it on themselves. They can apply however much pressure they want. And then you can do the injection. So these are very inexpensive, which is nice. You can order them on Amazon. If the kid you're working with really likes them, then we can certainly send you some, because the child life department has a ton. So that is one that's super easy to get a hold of. And again, by allowing them to sort of take part in their own treatment plan, it gives them ownership over everything that they're going through. And overall, they can be a lot more compliant when they do have that ownership. So, boom, cold spray, cold packs, ice packs. As we all know, cold can numb. So the cold spray, you can get Amazon, wherever, typically different pharmacies, things like that. But it makes it really, really cold. The one thing to take note of is some kids do not like the cold, because it is so intense with the cold spray that they would prefer to feel the poke, the stick, whatever, rather than feeling that really, really intense cold. So as you would expect, you can put it on the place where you're doing the injection, on your injection site, on your finger where you're doing the finger poke, whatever it might be. But you can also go back to that gate theory and put it above where you're doing that, and they can hold it there while you are administering the injection, while you're doing the finger poke, to sort of block that reaction from getting to their brains. So that is also another way that they can be involved, again, for them to sort of have a part in their own self-care. So moving on to the most fun one, the distraction. So the idea with this is, again, that same idea that we are blocking them from feeling all of the pain receptors going off by getting something else in the way. So distraction, these are some of my favorite ones to use. Little pop it ball. The ring rolls up and down on your finger, which feels really nice. I know it looks weird, but that one's really cool. Squeezing Play-Doh, picking out different shapes in a wand or something like that, search and find. So all kinds of different things. But the idea is to only use these items when it is time for an injection and not just whenever. So that sort of holds on to the nuance of the item and keeps it from getting desensitized. Again, this gives them a choice to make so they can choose what they are playing with out of their little pouch, what they are using for distraction. It also promotes some diversional play before it is time for injections. So a lot of kids do not mind the actual injection themselves, but it's more them getting worked up before that happens. And so by giving them something to hold on to, something to play with in their hands before that moment comes, that can reduce a lot of the anticipatory anxiety that they might be feeling. So all in all, these are some of the most common pain management things that we use here in clinic and over at the hospital. So they're all essentially here to distract your brain from feeling those full effects of pain sensations and just make sure that it is a choice that the kid gets to make. So they choose which pain management technique they want. Again, like I've said, giving them that control can increase compliance over time. It can make the pain management technique a lot more effective if they're the ones that are choosing it. And it allows them to be a part of their own medical care, which can go a long way. So that's all I have.
All right, I'm gonna thank you so much to Emily for presenting on child life interventions. One thing just to empower you guys is that if you've got a family that is struggling with needle phobia or any kind of issues with coping, or maybe there's just even some family dynamics to where a younger, older sibling is struggling from a new diagnosis, Emily is an incredible resource. And you can kind of tell the families, hey, if you're a kiddo at Bonheur, then you've got access to child life services. And we can consult Emily at their next appointment. The parent can call and ask for that. There might even be some resources that we could send them in the meantime over the patient portal. But she does a lot of consults with families. And one thing that she didn't say is she herself has type 1 diabetes. And so we know that that goes a long way with our patients, and then just families trusting what people have to say. So she's done an incredible job with our patients. She's done an incredible job too with promoting, I'm going to toot your horn for a second, with promoting medical ID bracelets. We know that that's really important just in general for kids to have. And so she can help them create a medical ID bracelet. So if that's something that, a patient is not super stoked about wearing, they really do need medical ID on them, especially if they're going off campus for any kind of field trip or anything of that nature, then they can always reach out to us and we can get them in touch with Emily to maybe create that, or we've got some free options and some different options in that arena. So that's super fun. There's like what's it called? Like a cutting machine?
It's a laser engraver and cutter.
A laser engraver and cutter. So cool. I just love it so much. The child life department is just absolutely incredible. And so if there are some resources too that you as a school need or questions that you have, we can get you in touch with Emily. And if it's not diabetes related, then maybe just the child life department in general. They're a phenomenal resource here at Bonheur, but also just in general for spreading education and just meeting patients' needs. Thank you for being patient as we figure out our computer situation. I'm going to stay on this computer for right now, even though I know it's not the best quality. I'm going to swap over our PowerPoint. So if you did get the email from me, you should have had a PowerPoint presentation in there. You can follow along if you'd like, but we'll have the slides playing as we go along. And we're going to kind of go through that. And All right, so we're going to go ahead and rock and roll with our school care plan webinar. The biggest thing that we're going to go over are the main topics of each of the sections of the different school care plans. They have been updated. They started rolling out as of May 2nd. So you may have some of these that came through even at the end of the school year last year that you saw, and there's some changes to those. We also have a new regimen of insulin dosing for our new onset patients. So that's very much new that we're going to go over. But in those emails that you got or that you can get forwarded to you, I did have some links for previous webinars. So our 2022 webinar, we had all of the different pump and technology companies come and present. We do know that technology is rapidly evolving. And so Anna is going to be going over some of the newer technologies that might not have been on that webinar. But go back and look at that. It's a great introduction to the different kinds of technology, diabetes technology, especially if you're a new nurse. And then our 2021 webinars, I think I've kind of spliced them and told you different times that you can go and look for certain things. In the 2021 webinars, there were some skill sessions with carb counting, with emergency glucagon, GBOC, and Baqsimi training, as well as pen teaching and insulin to carb and correction dosing instructions. So those are really great resources. So instead of going over the exact same thing every single year, we've kind of built on it as time has progressed. And so this is actually our 4th year of doing webinars versus in person, which is kind of wild. But we're grateful that you guys are willing to join us and participate in this so that we can best serve kiddos. So we'll go ahead and dive in because I want to respect all of y'all's time. These are just the topics that we're going to go over. You'll see it follows the flow of the school care plans. So again, if you got that email, we attached just blank copies of all the different versions. So Anna, there's 6 versions, right? 6 versions of the school care plan. And they're the main versions that we're utilizing. You don't necessarily have to print all those out, but there are little subtle differences between the different ones. And so Anna's going to go through all of those. And then you'll notice on some of the slides, there's a little light bulb. And that's signifying that there's helpful information that just might not be in the school care plan that we're going to go over. So that's just kind of the flow of everything. Again, Q&A as we go along, ask the questions. Depending on what time we get done, we will stay on for a little while after everything is over to do Q&As. You've also got my email if you got the emails from me. So if you guys are jumping in and out, or if you've got kiddos at school actually today, because I know some people have started back, you can also email me. And my email address is Erica, ERICA .Davis, DAVIS @Lebonheur, LEBONHEUR.org. And so you're more than welcome. I'm the lead contact person for schools, for school issues, for school concerns. So you can't email me direct patient questions, but if you're like, hey, can we find a time to like talk or meet up about a patient, then I'm happy to do that. Or if you've got a direct question about this presentation. I think that is all on there. And then you'll notice, so when you pull up the school care plan, at the very top, it's got some patient information. A lot of that is like their name, their date of birth. At the top, it does say their type of diabetes. Something to keep in mind, we don't have a slide on that, but whenever you're looking at a school care plan, there are the headers. And depending on where they are in their diagnosis, we truly may not know. There's a lot of things that go into diagnosing a patient with diabetes. And then every single day we're finding new kinds of diabetes. I was in a webinar at the ADA conference learning about mitochondrial diabetes. And I'm like, that's blowing my mind. I don't really understand that fully. So, we're learning more about diabetes in general. And that 2021 webinar also, if you were to go back on our website and go on YouTube, there is one about our new onset process. That's changed wildly over the years, so I wouldn't recommend necessarily watching that, but there is a part that does talk about type 1 versus type 2 versus MODY versus a few other kinds of diabetes. But it's not so cut and dry as just type 1 or type 2, or type 1s need insulin and type 2s don't. So I wouldn't necessarily center all of your care around that diagnosis, but more so about what medications they're on and what that patient actually needs. And so the actual diagnosis of type 1 or type 2 is not super relevant anymore in the terms of managing care. We're really looking at their blood sugars and looking at what they need. So that's there because you guys over the years have asked for it. And so we're going to do our best job to put the accurate diagnosis there. However, if they're a new onset diabetes patient, or if they're getting some kind of genetic testing, we may truly not know. So it might say new onset diabetes, or it might say type 1, and they're really find out later they're type 2. So it's not as cut and dry as it has been in the past as far as their presentation when they're diagnosed. So anyways, that's just something to keep in mind. And then it's got their name and their grade, and you guys can use that however you want. We're not necessarily filling that out for you. And then right under that, there will be this parent and guardian responsibility section. I'm not necessarily going to we're not going to necessarily read all these things for you. This has always been in the school care plan. It's just been at the very end. So we'll talk a little bit more about parent responsibility at the end, but something that we're hammering home this year for sure is that the parents are responsible for making sure they're communicating with the school about their child's diabetes all the way around to bring supplies and certain other things. So we are, as a clinic, really making sure that parents understand this. So they're responsible for keeping the nurse informed. They're also responsible for taking new school care plans up to the school. They get copies at every single appointment, and they'll get copies if they call us and the insulin regimen changes. And so they're responsible for getting that up to you guys and communicating those changes with you. And then there's a few other things here. So this, again, moved from the very end just up top so that it's kind of at the parents' first thing that they're reviewing, so that they make sure they understand what's being asked of them. So that, again, we'll talk more about later, because there might be some questions about some changes that we've had to some policies that we have from even emails that I've sent out to you guys back in May. But we're going to go ahead and dive into the 6 different kinds of school care plans. And so from that, I'm going to hand it over to Anna. If you did print out those different versions of the school care plan and you want to pull those up, now would be the time. But if you didn't print them off, that's fine too. They're more for a reference. We're going to have these slides that are going to have the key things you need to know about each of them.
Well, good morning, guys. Again, Erica did say my name, but my name's Anna. I am one of the diabetes educators here. So I'm going to be reviewing these 6 different type of insulin regimens. And so that's why we have 6 different school care plans, basically because we have 6 different insulin regimens we can prescribe. So I'm going to go with the first one. So this is called insulin dose calculations. This is one that I would say is probably the more common one a lot of people have seen. I'm going to review everything on here. I'm going to kind of show you what it kind of means, so that if you get a patient on this, you do know how to appropriately dose for it. But again, if you ever have any questions once you get orders, always feel free to contact us and we can help you with those orders of understanding. But just to go off the top, so in big, bold capital, it says if blood sugar is less than 70, treat low blood sugar per hypoglycemic protocol before giving insulin. You're going to see that on every single school care plan that involves insulin. We want to make sure that we treat a low blood sugar with a protocol, and we're going to go over that a little bit later. So for nutrition dose, that's going to be referring to our carbs that we're eating, the student's going to be eating. Next to that, you do see it says use, and then it gives a bunch of different brands of insulin. Those are going to be our rapid acting insulin. And we just put them all on there just because with insurance, brands can be changing. So we just want to make sure you're not like, whoa, this is a different type of insulin. So we just listed them all there for you. Then you see at breakfast, lunch, and dinner, it kind of says the same thing. So it says give 1 unit for every X grams of carbohydrates. So for example, let's say it says give 1 unit for every 6 grams of carbohydrates. What you're going to be doing is basically you're going to calculate how many carbs are in that meal. And then for this example, you would divide by 6. So if they had 60 grams of carbs divided by 6, well, that's even 6 units that they would get just for the carbs. Now, if it comes out like 6.5, things like that, you do want to round. And so underneath dinner, you see whole unit dosing and half unit dosing. I like to call this diabetes rounding because the half unit dosing is kind of weird. So it kind of gives you guidelines of like how to round if it's to 0.0, 0.5, things like that. This is also going to be an addition. We want to add a correction dose based on the pre-meal or before meal blood sugar. So correction dose is we're trying to correct the blood sugar if it's too high. So again, you do see those rapid acting insulin, but then it says for 1 unit for every X points above X at breakfast, lunch, and dinner. Now, I'm going to give you an example. So most of the time, you're going to see a target blood sugar of, let's say, 120. So it may say for every 1 unit for every 30 points above 120. So that 120 is our target blood sugar, and then 1 unit for every 30 points. So basically, we want to give 1 unit of insulin for every 30 points they're above their target blood sugar. Now, I know this is kind of a lot to think about, but the math that we do is we want to subtract the target blood sugar. So in this circumstance, we'd subtract 120 from that before meal blood sugar, and then we would divide by 30 to see how much insulin they need to correct their blood sugar. Again, I know that's a lot of math. So if you've never experienced an insulin regimen like that, feel free to call us. We actually have like a step sheet. If that would help you, we can send that out as well. Then you would use the same rounding. So we would either mark whole unit dosing or half unit dosing, depending on the kid. And then there's 2 bullet points underneath regarding the correction dose. So it says if glucose meter reads high, correction dose should be based on a level of 500. So referring to like if you're doing a finger stick, their blood sugar on their meter just reads high. We don't know how high it is. So most meters read up to 500. So we're just going to base it off 500. That's what we would do for that correction dose. And then for continuous glucose monitoring, also known as CGM, reading high, we do want to refer to the 504 plan regarding treatment using, if we want to, check it with a finger stick, or if we are okay using the CGM reading to correct the blood sugar that way. And then we'll talk about CGMs a little bit later. So if you don't know what that is, I promise I'll get to that. But if using the CGM reading, so if, we've addressed in the 504 plan, and they're like, hey, yeah, you can use the continuous glucose monitor to base their calculation off that. If it is the Dexcom, it only reads up to 400. So if the CGM was reading high, we would base the blood sugar at 400. If it's Freestyle Libre, which is another type, we would base it off 500. Then underneath that, there's going to be basal dose, and it says it has a blank for the brand of insulin because some of those long-acting insulins work a little bit different. So they're not necessarily as interchangeable. But then it says give X units of long-acting insulin at the same time every day. And we either mark AM or PM. A lot of times that medication is given at home, but we still do provide it on the school care plan. Then there is a spot for other medications. So like, for example, if they're on like metformin, things like that, that's where we would include it. So that is the first school care plan. The next one is sliding scale. So these are kind of our more common ones I feel like a lot of people see. So again, it still has the blurb of like, if still less than 70, we do want to follow that hypoglycemic protocol. Now for a sliding scale, just to let you know kind of how that works. The sliding scale below is based on a set amount of carbs as well as what their before meal blood sugar is. So if you see, it says each meal X grams of carbohydrates, we're going to have in there, maybe like an example would be 60 carbs. So that sliding scale below is based on 60 carbs. So we only want to use this sliding scale at meals, and we want to make sure they're staying around that set dose that's prescribed. We can go 5 to 10 off kind of each way, but we do want to stay close to that. And then you can see the sliding scale. It says give X units if blood sugar is, and then it gives a range. So then you would, of course, have, okay, we're around 60 carbs for that meal. Let's check the before meal blood sugar. Okay, let's say they're 220. Then you would look at the range of 201 to 250, and it says however many units it says to give, that's what you would give for that mealtime insulin. Now, it also then does have the basal dose similar to the one before. So, all right, so we have a little light bulb. So this is something that's not included in the school care plan. I'm about to go over the insulin pump regimen, but I don't know. I know there's some people on here who may not have had much experience with insulin pumps, or maybe you're an expert, but they have are ever changing with technology, things like that. So it's kind of just going to be a good refresher, or good for people who may not know anything about it. But this is saying, and part of my screen is covered, so give me 1 second. Oops, sorry. So it's a small device worn externally that gives insulin under the skin through a small cannula, which is changed every 2 to 3 days. So that's what that picture is showing, is the little cannula that's inserted in the skin. So an insulin pump would take place of injections. The pump will give background insulin throughout the day as set by the doctor. The only thing that the nurse or the student has to do is they need to enter their carbs and blood sugar into the pump to for their mealtime insulin to administer that insulin. So there are different continuous glucose monitors that are compatible with the insulin pumps to manage that background insulin. And there's also 3 different types of pumps. So I'm going to just show you the 3 different types of pumps. So the first one is Omnipod. It's called a tubeless pump. Basically, what that means is you can see the little white pods below. There's a cannula on the back of that. And so it's going to be inserted, and that cannula is in their skin. The pod holds the insulin. So you want to change, the student changes the pod every 2 to 3 days. But then they have a PDM, or what's called a personal device manager, that communicates with the pod. So that's what, you can see the little screen devices. So in order to administer insulin, they have to use their PDM, and they do need to be within 5 feet to deliver insulin for meals. Now, for that background insulin, they don't have to be that close to the PDM. There is, so there's Eros, which is kind of the oldest generation, then Dash, and then Omnipod 5 is the newest and greatest that everybody is talking about. The Omnipod 5 is compatible with a phone app, meaning depending on the type of phone, they can actually dose from their phone through an app. Or there's also a PDM that comes with it that communicates with the pod. And then the Dexcom G6 is compatible with the Omnipod 5. So they'll kind of talk to each other. The Eros and Dash are not. Now, Tandem is a tubed insulin pump. What's that's meaning is if you see the little, the pump smack dab in the middle of the screen, there's going to be tubing coming from that. And then in the bottom left corner, you see cannulas. So that cannula is what's inserted underneath the student's skin to administer that insulin. And that's what they would change every 2 to 3 days. So the compatible CGM is also the Dexcom G6. And then there are remote bolus options from a phone app for meals. They can also bolus from their pump as well. But just if you may see them doing something from their phone, that is a possibility. Now, Medtronic. So this is the 3rd type of pump. It's also a tubed insulin pump. So coming from the pump, there's going to be that tube and then the cannula that's inserted underneath the skin, similar to the Tandem. The compatible CGM, so this one's different. It's a Medtronic Guardian. So that's kind of close to the pump, the bottom left corner. That's what their CGM looks like. And you can remote bolus from an AccuCheck Link meter. You can also bolus from the pump as well, but those are the 2 options. Okay, now we're to the insulin regimen part for the insulin pump in our actual school care plan. So kind of to start off, it just says the insulin pump continuously provides, we have the different types of rapid acting insulin right there subcutaneously for the student. So it has manual basal rate. So that's going to be that background insulin. So it gives you X amount of units every hour. Again, this is programmed into their pump. It is not y'all's responsibility to check and make sure those settings are right. That is the parent's responsibility. So the only thing y'all have to do is, enter the blood sugar and carbs, and I'll get to that in a second. So again, now we're kind of going to now the meal part. So if blood sugar is less than 70, we do want to treat, with the hypoglycemic protocol, which we're going to go to in a second. But for nutrition dose, so that's going to be talking about our carbs. It kind of looks similar to that first insulin dose calculation, or what we call insulin to carb ratio. It looks similar to that. Then at meals, add correction dose based on pre-meal blood sugar. And it basically looks like that same insulin dose calculation school care plan. Now, at the bottom, it says provide nutrition and correction bolus per pump calculator by entering carbs and blood sugar in pump. So there is a way to go in the pump to bolus. That's what we call it. And you just enter the blood sugar and carbs, and it will calculate it by itself, the insulin that they need. So you will just, press enter, and it will infuse into them, which is really cool. Now for non-insulin medications. So most of the time, this is going to be some of our kiddos who may just be on metformin or things like that. So metformin is an oral medication. It is taken typically twice a day. And we sent kind of with the email, the kind of how we slowly increase the dose. There is a potential for side effects of like upset stomach, nausea, vomiting, and how we are able to sometimes prevent that is we want to make sure they have food on their stomach. So that's why it says immediately after breakfast and dinner. So if the student is eating breakfast at school, they will need to take that metformin at school. But if they're eating breakfast at home, then they should be taking that metformin at home. Then there's a slot for Victoza. It's a once a day medication. It's an injection. And then there's just other medications if we wanted to include any in there. So injected mixed insulin. This one's a fun one. You probably won't see it much. I feel like our providers kind of vary with how they like to do the injected mixed insulin. So I would encourage you, if you get one of these, look at it very closely. I'm going to kind of explain how our format is, but it may look slightly different. So at breakfast and dinner, it's going to look similar to a sliding scale. Now that's going to be with mixed insulin. So it says give X units of X insulin. We are going to put the specific type of mixed insulin in there. Then to the right, you can kind of see the meal plan. We're going to have a set amount of carbs for their meals and a set amount of carbs for their snacks. Then at lunch, we want to give a correction dose on their pre-meal blood sugar, and that's going to be non-mixed insulin. So that's going to be like our typical rapid acting insulin. And it's going to look like the insulin dose calculation, or we call it a correction factor. So we would subtract that target blood sugar and divide by whichever number they give us in there. Again, it may vary. So definitely look at that closely. If they are on something similar to this and they are getting breakfast at school, then we would want them to have both their mixed insulin at school as well as their non-mixed insulin. So this one can get, I understand, a little bit hairy. So definitely feel free to reach out to us to discuss the orders if you need help understanding them, and we understand. All right, so insulin to carb ratio and our correction sliding scale. So this is the one Erica was talking about. how it's kind of our new one. We're starting, if our patients are needing insulin for their carbs and to correct their blood sugar, this is typically the outline we give them. So you may start seeing this trickle in a little bit more. I think it's a little bit easier. You don't have to do as much math. So hopefully this will help. But I'll just review it with y'all. So again, it still says, the less than 70, we want to follow that hypoglycemic protocol for the nutrition dose. For the carbs, it looks exactly, it's going to be that insulin to carb ratio. So it says give 1 unit for every X grams of carbohydrates, which means, again, if it was 6 that we put in there, we would divide the carbs by 6, the total amount for that meal. Then we have the rounding, because we would want to round after we determined, divided by 6 in that example. Then we want to add the correction dose based on the before meal blood sugar. So the correction dose, instead of doing math, it's just a sliding scale. So it's going to be if blood sugar is basically between, let's say, for example, 151 to 200, give 2 units of insulin. You would just look at wherever the blood sugar falls, whichever range it does, and give that amount of insulin for the correction. So you would just add them together. And then you can see it has the same bullet points about like if the blood sugar is reading high, how to figure out a number for that. And then also about the basal dose below. Now, the next slide, this is the insulin to carb correction sliding scale. It's just like a helpful little sheet of like the steps. So if you're like, this is new to me, I feel like I want some practice or to understand it better, you can fill in the blanks for the student, and you can use that if it helps you. So it gives you 3 steps, which parents seem to love it too. So, and I think that is it for this part. So we can look at the question answers. If anybody has any, we'll just take a few minutes and we can try to answer them. If you have any about the new insulin regimen, anything Erica was talking about, just while it's fresh on your mind, definitely enter it in the question and answer, and we can try to answer them. Hand raised. Are you unable to mute? Perfect.
Can you hear me?
Yes.
Okay. I wasn't able to use the chat, I think because it's recording.
Okay. I'm
So it
sorry.
no, it's fine. I just wanted you to know.
Thank you.
But I think you mentioned something about we could have a copy of the PowerPoint.
Yes.
I didn't see it attached to my email, but I just wanted to see if we could get that.
Yeah, for sure. We can.
Because I know a couple nurses got called into IEPs and stuff, and I wanted to be able to share it.
Colleen, did you just register this morning?
I did.
Perfect. Yeah, I will, I'll go through all the people who registered this morning and send you guys all of these handouts for sure.
Okay, great. Thanks so much.
Absolutely. And one other thing too, Colleen, if you just jumped on, because I know you guys just heard of the webinar today, but we should have this recorded, and then what we'll do is we'll send that recording out to everyone that registered. So
Great.
even if you've got some other people that couldn't come, if you'll just have them register so that they can get all these emails.
Okay, great. I sure will.
Yeah, and then if we push anything out as the school year goes along as well, then that's the email chain that we'll be using as well. If we happen to have some resources later on this school year.
Wonderful. Thank you.
Yeah. If no one else has any questions, we'll stay on this, so we'll be here. But everyone else, if you want to take about 10 minutes to use the restroom, stretch your legs, and then we'll start back up so that we can finish out our webinar. But if you do have questions along the way, Anna or I will be here to answer them. So you can either raise your hand or put it in the Q&A section. I do think the Q&A section is supposed to be working. I'm so sorry for all the issues.
All right. We'll be back, guys. Thanks.
All right, guys. Woo. So sorry about that. All right. Well, I hope everyone got to kind of stretch their legs. I know that this presentation isn't always the most enthusiastic thing, but we're hoping that we can kind of just, especially for the new nurses who are seeing these orders for the first time, make some of it make a little bit of sense. So I think that everything's good. Let me know if you can't hear me, just raise your hand. So we're going to go ahead and dive in to some of these sections. And I just want to say this, I'm immensely grateful for some of our nurse partners. Some of them are on this call right now who have helped us over the years, really see some areas of concern or just confusing areas within our school care plans. And that feedback has really launched a lot of changes. So I know that it's a little irritating that we are always changing these school care plans, but just so that you've got kind of a little bit of backstory, every March, we submit our changes for the following school year so that it can get loaded into our charting system and approved by all of the parties that need to approve it. So really the process starts probably in January of the previous year. So these changes that we're talking about right now, we started in January of 2023 with really deciding what changes we wanted to make. And then with the anticipated go live date of May 2nd for both our charting system as well as just getting the patients, the school care plans in general. I know this isn't really the time to talk about that because we're kind of in the snack and school party, but this section in general is one of those sections that over the years has been something that nurses have found difficult to kind of understand and navigate. And so in this arena, it has changed a little bit for this year. And part of that comes with the new insulin dosing plan that we have. So the previous versions, if you've seen those, it says are snacks covered with insulin, yes, no. And that's kind of been a little confusing to both nurses here in clinic who are helping create these school care plans for providers, as well as you guys on the front line trying to figure out what that really equates to for your patients. So for those of you who don't know, our division chief is Dr. Catherine Sumter, and she came on as of January 2023. And one of her really big things is that there's kind of been a misconception over the years of snacks and dosing insulin for snacks. And I think we all really benefited from hearing her explain the mentality of why we would typically give snacks for different kind of occasions. So I'm actually gonna, let's see if I can skip slides. I'm gonna skip to the next slide just so that I can kind of break this down and then I'll go back to that previous slide. But we're really changing our terminology here in our clinic as well as with our patients, that when it comes to food outside of meals, we're trying to really limit the word snack to the appropriate terminology, meaning that if a patient, and especially this would be more so outside of school, but you guys are manning school events and competitive teams, activity treatments. So those are treatments that patients are using to maintain their blood sugar while they're doing vigorous exercise, either aerobic or anaerobic exercise. We're using that terminology of activity treatment, not snack, because they're not necessarily getting insulin or they're not getting insulin for those food items that they're eating for the purpose of keeping their blood sugar steady. One thing I will say is if you've got a competitive athlete that goes to your school and you're trying to help, if they're not already managing their own blood sugars outside of the school setting, and you're having to get involved with that, then they're going to need a consult with our dietitian team to be able to come up with a plan for them, because those super intense activities and competitive athletes, they need an individualized treatment plan. They need an activity treatment plan. And so that's something completely different from the school care plan. But for the most part, your kiddos aren't going to be doing that vigorous activity for longer than 30 minutes while at school. So anyways, that's kind of there. So activity treatment. And then we have low blood low treatments or the Rule 15 treatment. So that's if a patient has a low blood sugar. So we're not calling that snacks. We're calling that a low treatment. And that we'll go over a little bit in our hypoglycemia section of what appropriate low treatments are. You'll also need to communicate this with the parent that depending on what your school policy is, they may be responsible for bringing these things to the school. And then also you guys are going to need to talk about between yourselves, like where are these going to live? Where are these low treatments going to live? Are they carried around by the patient, or do they stay in the nurse's office? Do they stay with the teacher? Like what really manages that? But anyways, activity treatment, low treatment, and then we have snacks in between meals. So for some of your schools, you may have set snacks. I know like for some schools that offer pre-K and kindergarten, they have times where they all sit down for a snack. And that's been kind of hard to navigate over the years. And so I'll show you on this previous slide here in a second how we're going to manage that. But that would be something that definitely both the school nurse and the teachers and the parent need to talk about in 504 plan, just to figure out how the flow of the day is going to go for those patients. But when we talk about snacks in between meals, we are really recommending for our kiddos that they are not really having more than one snack in between meals. The more snacks they have, the more kind of all over their blood sugars are going to be, and the harder they're going to be able to be managed. So does anybody have any questions about that? Because I know that that's kind of a new topic as we go through. I'm going to keep just talking, but you can definitely ask your questions along the way. So this previous slide, snacks and school parties, right? So this is going to be applicable for any kiddo that has set snacks, as well as any kind of event. And so for the most part, most kiddos are going to have this first section right here where it says for insulin dose calculations, sliding scale, insulin to carb ratio, and correction sliding scale, you're going to have this section filled out. If for some reason you get a school care plan that it looks exactly like this and it's blank, then you need to let the parent know, because we need to know. We might have just had an oversight and not filled that in. But it is supposed to have some form of instruction in this area. If a patient is not getting any snacks, they should have at the top of their school care plan, it should say modified school care plan. And then this section may be completely removed. For example, we had a patient that we created a school care plan for yesterday, and they were only on a correction sliding scale, meaning that they were not getting any insulin for any food that they were eating. So they wouldn't have any insulin that they would be getting at this point. So that this whole section was removed for them. But for the most part, most patients should be getting this. And so the instructions are snacks are covered with insulin, all snacks. Any food given, if it's not an activity treatment or if it's not a low treatment, then they are getting insulin for that with these parameters in place. So we are giving the nutrition dose only. So that would be their insulin to carb ratio, and do not include a correction dose at this time. So they would give 1 unit of their rapid acting insulin, which would be any of these listed for every how many grams of carbs. So you'll see a number where that yellow box is. And the parameters with this as well are that snacks can be planned at least 2 hours before lunch or anytime after lunch. And then this insulin to carb ratio can be given at that time. One thing to keep in mind too, just in general with any kind of meal or any kind of food, is that you're going to see variable blood sugars up to 2 hours after they eat. So just keep that in mind, that their blood sugars may be higher after they eat, and that's totally normal, and their CGM might be reading that. And we can talk a little bit about that later if anyone has any questions about that, but that's part of why you're not giving a correction factor with this as well, because of that. And then for the insulin pump, it's super easy, right? Snacks are covered with insulin, and please enter the blood sugar for all carbohydrates into the pump calculator and give the recommended insulin dose. Part of that as well is that pumps have the capability, as Anna was talking about, to have different settings. So they may have different insulin to carb ratios for kind of weird times, like at 10 o'clock, starts 1 insulin to carb ratio, at 1 o'clock starts 1. So just whatever those doses are, then it's going to take that into the account. And I can't remember if you said or not, Anna, but most of these pumps work with continuous glucose monitors. And so it does all the calculating for you, and it's got something called insulin on board. And so it's going to give the appropriate amount of insulin based on what active insulin is already in their system. So you just trust that algorithm, you go with that. That's the instructions that we're giving you for that. And that's what instructions we're giving our parents as well. Parents may themselves override that at home. It's not necessarily something that we're asking you guys to do at school. So just kind of keep that in mind. Anything else you can think about with that? Okay. I know that that's new, so if you've got any questions, I'm hoping that it decreases the confusion when it comes to snacks in general. One thing as well about that is even if a patient is on a set sliding scale, they would have an insulin to carb ratio just for you, just for school, just for that setting. So they wouldn't necessarily be doing that at home. That's just for you guys to manage their blood sugars there at school. And then the diet guidelines, for the most part, our dietitians updated this a little bit, but the biggest thing is just these are recommendations. So we're asking to not add sugar to any meals or beverages. The biggest thing with that is if we can choose a beverage that doesn't have sugar in it, a sugar-free beverage is going to be preferred over one that does provide fresh fruit or unsweetened canned fruit, no juice except for to treat lows, and do not withhold scheduled meals, and encourage healthy food choices. Choose white milk over chocolate milk. One thing I will say with this section that we're not trying to get across to you is that everything is hard and fast. We do teach patients that occasional treats are okay. And so we don't want you guys to feel like, oh, well, a patient can't have a cupcake or they can't have that one soda if every single kid is having something. If there's a choice over a regular Sprite versus a Sprite Zero, well, we would want to steer the patient towards that. But in an environment with patients, the biggest thing is that we're giving insulin for the food that they're eating, for the carbs that they're consuming. So occasionally, if they want to take part in that and the parent is on board with that too, then that's perfectly fine. We want the most normal experience for our kids with diabetes while keeping them safe, but they're going to be kids. So just making sure that we're giving insulin with that. So those occasional treats are fine. So I think I'm going to hand it over to Anna, and she's going to be going over blood sugar monitoring and continuous glucose monitors.
All right, guys. So just talking about checking for their blood sugar. So what is first pulled up is for all the school care plans. So all 6 of them except for the non-insulin medication ones. And I'll go over that in the next slide. So just to go over, we want to make sure that if their blood sugar is going less than 70 or over 250, that we're notifying the parent. We do want to allow the student to carry their blood sugar meter and or their CGM receiver or phone if they have an app for that CGM. And I promise I will go over the CGM in a second with them at all times, plus any necessary supplies to perform the blood sugar testing and then emergency food. The student's ability level will be determined by the school nurse and parent as specified in their yearly 504 plan on who will be, checking the blood sugar, things like that. The times we are requesting blood sugar monitoring for these specific school care plans is going to be daily before meals, when the student feels high or low, or if you notice like they're exhibiting symptoms of high or low blood sugars, and then before PE or any type of exercise. Now for non-insulin medication, so this is going to be like maybe a patient who's just on metformin. So when do we want them to check their blood sugar? So it varies depending on the provider. So you can see there's a little highlighted section that says per MD. We are going to fill that in, the nurses will. It may say like before breakfast and 2 hours after dinner. So it may not apply to you guys, but just make sure you check that section because it will be patient specific. And then the only other times that we would want to check for the blood sugar at school would be if they feel like they have a high blood sugar, and we'll review signs and symptoms of high blood sugar in a second. or if they are, feeling, you notice those signs and symptoms as well. All right, we are finally at continuous glucose monitor. So there's advertisements. So y'all may have been familiar with continuous glucose monitors already, but if you haven't, I'm going to do just a brief overview. So a continuous glucose monitor, also known as CGM, it's a small device that sends blood sugar levels to a reader every few minutes. So hopefully decreasing the number of finger sticks that student needs. So I'm actually wearing one. So I don't know if you can see it. I have a cute little sticker on it, but this is the Dexcom. So that's going to be the small device on their arm. And there is kind of like almost like a hair-like wire underneath. And that's what's reading my blood sugar. And it can read it some devices every minute, some every 5 minutes. There is a reader that you see. So there's 3 different types of continuous glucose monitors. So we have the Libre, there's Dexcom, and then there's the Medtronic Guardian. So for all of these, there is an app that you can use on the phone if they have compatibility, or if they have a phone, or there's a reader for most of them. Not everybody has to get those. So anyway, that's kind of why we put that we want to allow the phone or reader at all times so that the student is aware of their blood sugar. Now, with a continuous glucose monitor, we would absolutely love if everybody could be on it. However, there are times that insurance does not approve it, sadly. It may be too expensive, the copay for some families, or some people may prefer finger sticks, and that's okay. It's great, like if you're like, hey, like I saw somebody else who had this, but just be mindful that some people can't qualify or can't afford it. So that may be why some students are still doing finger sticks. If you want to know more about the different types of continuous glucose monitors, there's actually virtual trainings provided by the specific brand. So you can scan these QR codes, sign up for them. There's also a million different videos online if you just Google the specific brands, and they have videos of like all the different things, setting it up, things like that, if you are, you just want to know more about it. So, all right. So now what is in the school care plan regarding the CGM? So this is going to be in all the school care plans, and it just says if available. So like if it applies to them. So for decisions regarding use of CGM for treatment of blood glucose values, refer to 504 plan. So people do it differently. Some people solely rely on the continuous glucose monitor to dose, maybe for their meal time insulin. Some parents like to verify it with a finger stick. So that's why we want that to be addressed in their 504 plan as to how do we utilize this. Now, the bullet points below with the CGM, if it's available, we want to respond to low blood sugar, so less than 70 from the CGM, by following the hypoglycemia plan below, and it's below in the school care plan, and we'll get to that. We also want to respond to high blood sugar, so greater than 250 if 2 hours after a meal. The reason we put this little blurb in there is I was noticing I was getting a lot of calls from school nurses. It could be parents, and they're like, we're always checking ketones right after a meal. And it's because, the CGM is reading every 5 minutes, every minute. So you're going to see those spikes after meals. So they may spike to 250, 30 minutes after a meal, but if you check ketones, there's still nothing we can do about it at that time. So that's why we kind of encourage, if after 2 hours, the CGM is still reading above 250, okay, now let's check for ketones, because if they have ketones, then we can do something about it. And then we do want to allow the student to have access to the CGM receiver or phone at all times so that they can see their blood sugars. Any special accommodations related to like data sharing with school nurse, things like that, school Wi-Fi access, calibration, or even having to replace the sensor while at school needs to be determined by the school nurse, the parent, as specified in their yearly 504 plan. All right, we're going on with all the fun technology that's been kind of exploding in the diabetes world, which is exciting. But the NPen, so we've started prescribing this a little bit more. So you may have seen it, but it's really cool. So I just want to give you a general overview. So it's a smart insulin pen. It connects to an app on the phone. So you can see the little blue pen device. It's basically reusable. So you fill it with insulin cartridges, and they can use that for about 28 days until the insulin expires, and then you will replace the cartridge. So the app on the phone can help calculate the insulin dose by entering the carbs in the blood sugar. So it's going to have their settings in there. And they talk to each other so they can log things like that. So it kind of just helps, the family not have to do, all the calculations things. It kind of just eases and makes life a little bit easier potentially. So it's a cool device, but you may just be seeing that. Now, what did we include in the school care plan regarding the NPen? So this just applies if they have one, of course. But it says using the NPen calculator can calculate the nutrition and correction dose by entering the carbohydrates and blood sugar in the NPen app. Due to programming and other features in the app, the dose may appear different than calculating manually. So if the patient is using NPen, please address in 504 plan decisions regarding the use of NPen app for calculating insulin dose. So some parents like the NPen app, they like to dose based on that. Some parents may not use it, and that's okay, but that would be something that the parents would need to address in the 504 plan as to whether or not to use the app for the NPen. All right, so for hypoglycemia, I'm going to let Erica take it away.
Okay, so for most of you that have been school nurses for a little while or are familiar with their school care plan, this section really hasn't changed all that much, but I'll kind of run through just the gist of it so that if you're a new school nurse, you can kind of follow along. At the top, it's got some of the signs and symptoms for low blood sugar. These are things that you want to make sure every single person in this kid's life at school knows. And that includes bus drivers, school, all the teachers, all the, not extracurricular, but the art teacher, the PE teacher, like all of these different teachers need to know in general these signs and symptoms of low blood sugar, because depending on the age of the kid or even just what's going on, they may not realize that they have a low blood sugar. I'll divert just a second for a little story. One of my favorite stories is we had a cheerleader who was in middle school and then high school, and all of her cheer team had low blood glucose treatments with them so that they were ready if she needed them. And they all knew the signs and symptoms and they all had her back. It was a really sweet thing. I know that that's not necessarily the case for all kids because they don't want to show that they have diabetes, but it is really a cute thing when they are willing to share and willing to say, hey, are you willing to have my back? So then it's not necessarily on all the adults, but depending on the age of the kid, they can also have other people who are looking out for them. The biggest thing is just whatever communication method you want to have with the parent to notify them that there was a low blood sugar. We don't want to leave the student alone or send anyone alone before treating the low blood sugar. So my recommendation is that you guys work together between the parent, between the school, between the teachers to figure out something that works for you guys. Is the child old enough? Are they in high school and they can carry their own low blood glucose treatments? Or does the teacher need to keep it because the kid only brings Skittles and they're going to eat the Skittles all day long if they're in their backpack? So, that's going to have to be decided amongst you guys in the 504 plan, but definitely having quick access to those treatments. I know some parents are very proactive and they have little boxes in every single classroom that their kid travels to so that they're ready for any kind of lockdown or emergency that happens. But anyways, just having access to those, having access even in the the classroom, if at all possible, to check their blood sugar, whether that's with a CGM or whether that's with a blood glucose meter. Just having access in general is huge, so that they don't necessarily have to leave the classroom and they can kind of keep on with their normal life even in those environments, because there is a risk with kind of going to the school nurse's office or whatever. We just don't want the kid to be alone. But whatever works for you guys, safety wise, and then for that particular kid, because every kid is so different. And then just making sure that you know that unconsciousness or seizure is possible if symptoms are not treated. So we don't want to prolong something. So the more access we have to those low treatments and the more capability to let the kid know, hey, you're safe in this environment. You can tell us if you don't feel well. We can check your blood sugar, those kinds of things. Fast acting carbs should be readily available at all times. And you'll see under number 1, there's a list of the most readily available products. Not all carbs are created the same. We want something that is a fast acting carbohydrate. Anything that's got fat or protein in it is going to take longer for that blood sugar to pop up. And even when it does, then it can stay a lot higher for longer. And so all sweet things are not created equal. And so we've got a list here of the recommendations, and you guys are going to have to work together with the parent. Are they bringing these options? Are you supplying these options? We make it very clear that they're responsible for having that conversation for you guys to figure that out. And for the most part, there are some glucose products on the market. So we've got the biggest 2, which are those glucose tablets or glucose gel. The recommendations for those, or the serving sizes, kind of differ, so you just kind of need to look at that. But the rest of them are just very standard ones that we endorse. If there's anything else that a parent's requesting, you guys can address that in the 504. It's not necessarily something that we're going to recommend in a school setting. If they want to use another kind of treatment at home, that's fine. But we make it clear to them too, hey, treatment at school and treatment at home are kind of different. So there's this as well. And as you go through, you'll see, like, if the blood sugar is less than 70, then we're going to treat one of these things. And then we are going to keep checking every 15 minutes until the patient is above 70. And then there's 2, and they'll keep doing the treatments. They can either change, they could do Skittles, and then they could do glucose tablets, or they could stick with the same thing. It's okay with whatever they choose. And then you'll notice, like, as you go along, there's recommendations of what happens if you're close to a meal. So if the blood sugar is greater than 70 and the lunch or snack is less than 1 hour away, you're good to go. Just keep on with your normal routine. But if it's greater than an hour till the next meal, then they need a snack with both carbs and protein. And those are 15-gram carb snacks. So we've listed out the recommendations that we have that we tell parents. If there's something else that a parent wants, then you guys will have to kind of work through the carbs and figure out if that's something that's shelf stable, or that's, applicable, or just feasible in general. And you can address that in your 504 plan. But again, these are the ones that we kind of are recommending to our families. And so as we go along, we do have, if a student experiences a loss of consciousness or seizure, you can administer emergency glucose treatments. And so this is going to be if a kid cannot safely eat or drink, or if they have completely lost consciousness. We don't want you on the last slide, if it's to the point where you have to rub something on someone's gums or something of that nature because they can't safely swallow, we don't want you putting anything in their mouth. So you would also be giving this at that point too. But the emergency low treatments differ. And so you may see a patient come in with different ones throughout the school year. And so that's why we've listed them all. And I know it looks a little ridiculous to have all of these listed out, but the goal of that is if they are changing between treatment options, that you've got all the instructions for every single one of them. And some of them have specific weights, weight parameters listed. And so we will, for the most part, have weight listed in those yellow boxes. But if you also have a scale and you want to weigh them, you're more than welcome to do that as well. If that box is not filled out, or if you just want to keep things up to date for yourself. If you're like, hey, I think you've had a growth spurt since this last school care plan, that's fine too. That's just there as an extra thing to help you. Glucagon is going to be the mixed kit that's either in a red or orange or white kit, and it's got a diluent and a powder. You actually have to mix those together for it to be useful. Otherwise, you're just given the diluent and no medication. So make sure that if you are a new school nurse, you go back and you watch the video from 2021 about the different kinds, or you can look up these products, and all the websites have instructional videos on there. Glucogen is the same thing as glucagon as far as mixing it. There's just a little bit different weight parameters, so just keep that in mind on there. Bactemia is the nasal glucagon, and so that's on there as well. It's just 1 dose of that. Gvoke and Zegalogue, the last two are auto injectors, and so they work somewhat similarly to an EpiPen, but I would go and I would read the instructions and go back and watch those videos. You do have to hold it until it clicks and then keep holding it there. So just something to keep in mind. You don't want to just give it and then pull it straight back. You do want to hold it because Zegalogue and Gvoke are subcutaneous injections. So anywhere that you give insulin, you can give these, but they're not going to be an IM injection like the glucagon or glucogen. So just keep that in mind. No. If you've got any questions about this, save them for the end or put them in the Q&A section, and we're happy to answer them. And then we're going to jump to the high blood sugar, so the hyperglycemia section. Oh, one thing I was going to say with hypoglycemia, the goal of just if they are less than 70 and they're conscious is we're not saying that they have to go home for hypoglycemia. If you have a policy at your school around hypoglycemia and sending patients home, we just ask that you discuss that policy with that family, because in these instructions, of course, if you are giving any kind of emergency rescue medication, you're calling 911, you're calling the family, that's a whole different scenario. But if they're conscious and they're just doing this aspect of the rule of 15, then we're not saying that as Le Bonheur that they have to go home. If you make the call, then just discuss that with the parent. All right.
All right, so we just talked about low blood sugars. Now we're going to the other side of things with high blood sugars. So there is a few different ways we treat high blood sugars depending on which school care plan. So I tried to kind of break them up. So this one that you're seeing, it's for the insulin dose calculation, injected mixed insulin, and then the insulin to carb ratio and correction sliding scale. Most of them are pretty similar, so I'll just point out kind of maybe differences in the other ones. So at the top, you can kind of see the signs and symptoms of high blood sugar. So this is, again, kind of what we were talking about. If you see the patient with any of these signs and symptoms, you may want to go ahead and check their blood sugar just to make sure that, we're not cruising at 300, 400. If they are vomiting, that can be a sign of what we call diabetic ketoacidosis, which is very dangerous. So if they are vomiting, we do want to check their blood sugar, and we do want to check their ketones. Even if you check their blood sugar and they're not above 250, still check ketones if they're vomiting. Now, let's review the steps. So the reason we want to address high blood sugars is because they can start spilling those ketones, and those can be dangerous. So this is kind of the guidelines for it. So if a blood sugar is greater than 250 and a student hasn't eaten in the past 2 hours, we want to check for ketones. If the ketones are negative, the student may remain at school and continue to treat student as usual with insulin as detailed in the insulin regimen section of the school care plan. Basically, that's saying, let's say you check them at 10 a.m. And their blood sugar was 300, their ketones are negative. Well, okay, we're, in an hour, we're going to check them for lunch. So we would just resume as normal, and then we'll just recheck them at that lunchtime and then give them the insulin based on that. If their blood sugar at that point is still above 250, and we would also, check for ketones at that point. Now, if their ketones are positive, when you check, we do want to notify the parent, and then we want to go to step 2, which is right below. Step 2 says initiate the following plan of care for positive ketones. So if trace and small ketones are present, the student may remain at school at that time. We want to administer insulin according to the correction dose as detailed in the insulin regimen section. That correction dose, again, is to correct the blood sugar. If the ketones are present at lunch, then administer insulin per the insulin regimen section. So basically, we can just give, their typical amount of insulin, like using the correction dose as well as the nutrition dose. We'll just add those together. All that insulin will help them with their ketones. Then we want to provide sugar-free fluids every hour for 2 hours. So kind of the best way to get rid of ketones is water or sugar-free fluids, anything with 0 carbs and insulin. That's the perfect remedy to get rid of them. So again, we want to be pushing fluids. We kind of say like 1 ounce for every year of age, every hour. When it's been 2 hours, then we want to recheck their ketones and recheck their blood sugar. At that 2-hour recheck, if any ketones are present, even if they went from small to trace, so they digressed, we still want to first administer the correction dose detailed in that insulin regimen section, but the student must go home regardless of the blood sugar value. If at the 2-hour recheck, the ketones are not present, the student may remain at school regardless of the blood sugar value. Now, if let's say they had positive ketones and they were moderate to large right off the bat, we first want to administer that correction dose, so correcting that blood sugar detailed in the insulin regimen section. We then want to notify the parent that the student will have to go home immediately. The reason we kind of laid it out that way is you would have to be giving a dose of insulin every hour. So it's just for y'all's sake, as well as I don't know if the student would get that much staying at school. We just think it'd be best if the student went home and their parents took care of them at that point. At the bottom in bold, it says a student with hyperglycemia require unlimited access to the bathroom as well as access to water due to his or her symptoms. Don't allow them to play or exercise when ketones are present. And then our number is below. So if you're like, this is the first time, or maybe this is the 7th time, but this is a new insulin regimen, or hey, it's been a year since I've had to do this, you can always call us. We get calls all the time from either parents or school nurses needing help on like, hey, I just want to make sure I'm following this correctly. We will gladly help. All right, so now for the sliding scale school care plan, everything is exactly the same. The only thing different is in step 2. So with that sliding scale, we said there's a set dose of carbs that are added in, insulin's added in to that sliding scale. So we can't, based off that blood sugar value on the sliding scale, dose for ketones. So what we did is we put a insulin to carb ratio in here under step 2 that you can follow. I'm sorry, not an insulin to carb ratio, a correction factor, so that you can just follow that to correct their blood sugar regarding ketones. If this is blank, sometimes it gets skipped. Definitely give us a call and we can help you at that point. But everything else is the same. It's just we added that one little section for the sliding scale school care plan. Now for non-insulin medication. So this one, typically our doctors don't prescribe ketone test strips. So this is kind of why we made this blurb. So it says if blood sugar is greater than 250, student hasn't eaten in the past 2 hours, we ask that you notify the parent and request that they call a Bonheur. The reason for that is if they're not on any insulin and they're spilling ketones, that is a concern to us. And we do want to assess to see what kind of we need to do in that situation. So we'll probably have to talk to the doctor and see what we need to do. But it's not for y'all to figure out. So, and then it also has, if, they're dealing with a high blood sugar, having that unlimited access to the bathroom and water as well due to their symptoms. Okay, so insulin pump. So this one, I will say, the ketone management it doesn't look like it, but it is simplified compared to what we have taught them to do at home. So if the parent's like, hey, this isn't what we're doing at home, you can tell them it states it in here that it is simplified, and we have done that. So I'm going to review it. Again, if you ever get a patient who has ketones on a pump and you need help, always feel free to call us. But it kind of starts the same. So if the blood sugar is over 250, student hasn't administered insulin the past 2 hours, we want to check for ketones. If they're negative, student may remain at school, and we just want to treat as usual with the insulin regimen. Now, if they're positive, we want to notify the parent, go to step 2. So we're going to now initiate the following plan of care for positive ketones. And in parentheses, it says school ketone management is simplified from home ketone management. There are a lot of cool tricks that we can do at home to hopefully get rid of the ketones faster, but it's a lot of managing the pump, and it's just too much to tell y'all to do. So that's something, it is a little bit simplified here. So if they have trace or small ketones, the student can remain at school. We do want to administer insulin according to the correction dose found under the insulin regimen section. So Erica was kind of talking about how the pump can factor in active insulin time. So that may be it's subtracting some insulin because maybe their dose of insulin was 2 hours ago, and they may still have some in their system. So it may require a manual input because that pump calculator is taking away active insulin. So if you need help with that, definitely give us a call. If the ketones are present at lunch, then we will just go ahead and put in the using that insulin regimen section. We do want to provide sugar-free fluids over the next hour. Now, this is where it kind of gets a little bit different. When it's been 1 hour after tracing small ketones, we do want to recheck the blood sugar. The reason we are rechecking after an hour is we are making sure that their pump site is working appropriately. So how we do that is if it hasn't gone down by at least 50 points, I'm concerned that their pump site may not be working appropriately. So that's what this little blurb underneath says. So at the 1 hour recheck, if the blood sugar has not gone down by 50 points, then we want to administer insulin by injection according to the blood sugar correction dose found under the insulin regimen section of the school care plan. Now, then the pump infusion site will need to be changed and the pump function assessed. So for decisions regarding who's going to change the pump site, that needs to be addressed in the 504 plan. At the 1 hour recheck, if the blood sugar has gone down by 50 points, that has me thinking, okay, that pump site's still working. Let's just continue on with the ketone treatment. So we just then want to continue pushing fluids for the next hour. Now, when it's been 2 hours since ketones were first detected, we want to recheck for ketones and recheck blood sugar. At the 2 hour recheck, if any ketones are present, student must go home regardless of blood sugar value. So that's the same as the other school care plans. At the 2 hour recheck, if ketones are not present, the student may remain at school regardless of the blood sugar value at that point. Now, with moderate to large ketones, if they're present when they're first detected, we want to administer insulin according to the correction dose. We can do it through the pump. It may require that manual entry as well, but then we need to notify the parent, and then the student will have to go home immediately. I know that one's a lot more. So if you'll have questions about that, definitely put it in the Q&A and we can try to address them. But again, we are here to help. So if you ever feel like you need help, definitely give us a call. But the next sections regarding physical activity guidelines, I'm going to let Erica take it over.
Sorry to make you guys dizzy with us changing back and forth. We just figured you might want a break from seeing the same face the whole time, but you've made it to the last swap off. So I'm going to be talking about physical activity guidelines. Unfortunately, our dietitians couldn't make it today, but just to give you guys an idea of our clinic setting, we have diabetes educators that are both nurses and dietitians, and our dietitians are very heavily involved in everything to do with food, of course, but also activity. So they are helping us with this. So I'm not sure if you guys are familiar with the different activity guidelines of the ADA as well as ADCES, which are two bodies that govern diabetes care and really steer our management of diabetes, and everything is wildly evolving. And so the dietitians brought it to our attention that physical activity guidelines have changed for 2023. And so it's kind of a juggle to figure out how do we incorporate that in a school setting for you guys that works while both sticking to the recommendations of those two organizations, the American Diabetes Association and the Diabetes Education Care Specialist. I just butchered that, but anyways, the two governing bodies. So anyways, we have created this grid. And I'm hoping that by creating this grid, it makes it a little bit easier to guide what you guys are supposed to do in activity settings. And so we definitely want you guys to figure out if you're checking the blood sugar before PE or strenuous exercise. If PE or recess occur immediately following lunch, a blood sugar check may not be necessary. So you guys need to talk about that in the 504 plan. Life is both better but more complicated with more data. So CGMs provide great information in the source of arrows as well. And so you'll notice that on the CGMs, and I'm sorry, Anna, if you had already mentioned that or not. But you know, if a kid is you know, has a blood sugar and they've got an arrow going up, then that gives you a little bit more confidence than if it's got an arrow going down at times, depending on what's going on. So the more data that can be used in this kind of scenario, you guys can figure that out together as far as what works for that kid's schedule. And I know kids' schedules also change frequently, or they may start out one way with their schedules at the beginning of the school year and change a couple weeks in. So you guys have the ability to kind of figure that out when it comes to immediately following lunch, or maybe even immediately following breakfast or something. And so I see that there's a hand. If you don't mind just right now asking that question in the Q&A, and then we can always come back to this slide. So just so that you guys see, is the student okay for exercise? Less than 70, we definitely want them to go ahead and follow that rule of 15. Once the blood sugar reaches 100, then student is okay to exercise. The recommendation of 70 to 99, no exercise, get 15 grams of carbs and wait until blood sugar reaches 100 to start exercise. And again, there's some examples there of what that entails. Just so that you guys know, the threshold for exercise by those governing organizations is anywhere from 120 to 160. So we actually have dropped this just because we do know that the physical activity at school is a little bit different. It's not necessarily as strenuous all the time, and it can be shorter and shorter bursts. So this was a call that we made, but that aspect of activity treatment, that's exactly what that is right there. The no exercise, they need to be at 100 to be able to exercise. So 100 to 249, yes, they can exercise. You'll see in the 250 to 350, we know that if the kiddo is over 250, then they need to check for ketones. If they've got negative ketones, they're good to go. If they've got positive ketones, then you're going to refer to that hyperglycemia plan. And then the recommendations from the American Diabetes Association is that if the blood sugar is greater than 350, then we're going to avoid exercise. No exercise, follow the hyperglycemia plan, and avoid exercise until the blood sugar is less than 350 and no ketones. So that is a new recommendation, but part of the reason why that we're asking parents to send the school care plans is they need to read this. So we're telling them these things, and these things have changed, but they also are responsible for knowing the difference here. So if they're like, oh no, that's not what the orders say, and you're like, no, actually, you know, Bonheur has changed the recommendation, so you need to go back and read that. And if they have questions about it, then they can reach out to us. If the patient has symptomatic hypoglycemia or hyperglycemia during the activity, whether that's recess or PE, then they need to check the blood sugar. And then for every 30 to 60 minutes of exercise, student may need 10 to 30 grams of carbohydrates to prevent a low blood sugar. And then for decisions regarding treatment for extended activity, please address in their 504 plan. So I know we have a couple of patients that they have like a basketball practice at like 7 to 8 in the morning, and it's like one of their periods and like school periods. And so you guys would need to address how you want to manage that in that 504 plan, because depending on what kind of activity they're doing that day may guide that. And like I said, our dietitians can help with some of those recommendations. A lot of that's going to be through trial and error though. So there may not be a set thing. And a lot of the times those kids are going to be a little bit older. So you may be fine with them kind of managing that on their own for those kinds of activities. Another example of this might be like a yearly physical fitness test. I'm not sure what they call them anymore. But those physical fitness tests may be a solid hour and they're really moving, or they're for some schools split it up and it's not as rigorous and they do one part one day and one part another day. So each school is very different. So if you have like a special event or something, then just address that in the 504 plan as to how you guys want to move forward with treating for activity. And then the parent would need to reach out to us if they're needing more guidance on that. The recommendations for home exercise are different than school exercise as well. So they've got a chart like this, but like I said, the actual exercise recommendation, it starts at 120 or 160, depending on the patient. And so with just the parameters of school, we kind of kept it the same as it's been before. Okay, so that's it for the actual school care plan content. So now we move into just updates for you guys. So again, I sent out an email back in April to all the school nurse leaders, and just let you guys know that there are some things changing with our forms and our school care plans. So as of May 2nd, 2023, diabetes school care plan forms and school forms will no longer be faxed directly to schools. Diabetes school care plans and other required school forms will be available to the parent, and the parent will have to bring those to you or get those to you, however your communication methods are. Parents are given school care plans at every in-person clinic visit through the patient portal. We can also mail them to an address, or they can pick them up at the downtown or Humphreys locations. The Humphreys locations, it's only if they've got, if they call ahead and ask us for it, and then it's a signed document. So just to give you guys a little heads up about parameters that we've put in place here to hopefully turn things around quickly for you guys, we've actually created what we call our diabetes back to school hub. So myself and one of our other educators, Kelly Leggett, as well as a few other members of our team are being diligent about, as soon as those requests for school care plans come in, we're turning them around, we're creating them, and we are sending them over to a doctor who has been assigned to sign those. We will be doing this for the entire month of August. One thing I do want to mention is I did catch wind of some schools saying, oh, well, we told our kiddos that they don't have to have a new school care plan until September. Come September, we won't have any of these extra parameters in place to help families. So if a family needs a school care plan, they need to be calling now. We also have some slots that if we've got a patient that's completely lost to follow-up, we can do our best to get them in as soon as possible. Otherwise, they may not be seen until October. And so we definitely do have parameters in place right now in August to get this stuff turned around quickly to you guys. And again, we are communicating through the patient portal. I know that this is frustrating. There are a couple of reasons for this. And the first reason being that the patient or the parent needs to verify the patient's current doses, because doses change frequently. We also need to assess if there's any issues. So they need to call to request any school care plan so that we can verify those doses with the parent so that we can actually create a correct school care plan. And then also they need to read it themselves to know what they're consenting to. And then they need to sign that and get that over to you guys. So that's part of it. The other thing is, even with any forms that you guys send us, parents did make it clear that they didn't necessarily consent for us to say certain things or write certain things on a form. And so they need to review whatever we're sending to the school, and then they need to reach out to us if they don't agree with something that we've written on a form. So that's also why even the forms are going to be going through the parents. I know that it's frustrating, and I am immensely sorry for that. We definitely are trying to empower patients and families so that they can know what the orders are, so that they can advocate for themselves and be part of the conversation. So anyways, there's that. And I have a feeling there's going to be some questions about that. So I'm going to go ahead and move to the next slide. This is a fantastic resource. If you are a fairly new school nurse leader, or if you are a new school nurse in general, it is a massive resource about helping children with diabetes succeed at school by the American Diabetes Association. They just updated it, I think, as of June 2023. So it is really up to date. The American Diabetes Association has wonderful resources for you guys, and especially if you're training other people. So there's that. And then also we have a partnership with our local JDRF chapter. So that's our Juvenile Diabetes Research Foundation. They do incredible things in waves of research for treatments for type 1, as well as just advocacy in the Memphis area. And so they are having a summit. And this is the information for that. If anyone's interested in attending that event, the keynote speaker will be our chief, Dr. Catherine Sumter. So that's super fun. There's going to be breakout groups and other things. So you can register there. You can also pass this along to any patients if they're interested. We've got forms all over our clinic telling them about this. But that is the end of my slides. And so if anyone's got any questions that you want to drop in the Q&A, I think we've got one to start off with, or if you want to raise your hand if you'd rather verbally ask it. Anna's got one for us. What is that question?
Yeah, so Julie sent this, and I thought it'd be good for everybody here, but it says if a student on a pump is not yet less than 70, but has 1 to 2 arrows down, I'm assuming regarding their continuous glucose monitor, what are your recommendations?
That's a great question, Julie. So the thing is that when we make these school care plans, we have to make them easily enough usable for our patients and for any school personnel who uses that. So there are no set recommendations right now for the use of arrows in the treatment of blood sugar. We do know that. And so I would definitely talk about that in your 504 plan. If you guys want to put some parameters in place of how you want to manage that, it's totally appropriate. It's really hard to articulate that in any kind of school care plan setting. It is something that we are working on, but there's no created recommendations yet. But you're correct. If they're not yet 70, but they've got double arrows down or something, then they will be below 70. And so that definitely is going to have to be a conversation with the parent. Do you have any other thoughts on that?
So just to piggyback that, I'm also on an insulin pump with a Dexcom, and I'll come up here.
Yep,
so y'all can
go right
see
ahead.
So I also have type 1 diabetes. I'm on an insulin pump that talks with a continuous glucose monitor. So I do understand that question. So it is tricky. Our school care plan doesn't outline that. And I just kind of reiterating what Erica was saying is it's hard because also it depends on the circumstance. Like, are they about to go play? Like, or is it, they're going to be sitting in a class? Because different types of pumps, and I'm not going to try to overwhelm y'all, but with those compatible continuous glucose monitors, it's also trying to prevent you from going low. So it may stop the background insulin so that it helps prevent from going low. So just kind of the same thing. I think it would be best to address with the parent to see if they have anything they recommend, or if it's like, we just start using the rule of 15 once they hit 70. Because right now we don't have those parameters, but we are looking into that and trying to see if we can potentially accommodate that one day. So any other questions?
I don't see anything. I will say too that it is something we're working on. So I'm hoping that maybe we can formulate something for you guys for next year's school care plan. So Anna is actually going to be leading some overhaul that we're going to do with just diabetes technology in general, about how we introduce technology to patients and how we do our education. And so I'm hoping that over the course of the next couple of months, we're able to address this further. But for right now, anybody else have any questions? You can raise your hand or you can use the Q&A section. We're going to stay on for about another like 5 minutes just to make sure nobody has any questions. We can stay on as long as we need to, but I do know that we said that we would try to wrap it up at 11. So it is 11 for anybody that needs to hop off and get back to their normal day. But we'll stay on for till 11:05 if you want to raise your hand or you want to use the Q&A feature. If you don't feel comfortable asking a question in this setting, like I said, you're more than welcome to email me. Again, my email is Erica, ERICA.Davis, DAVIS at Lebonheur, LEBONHEUR.org. So that's always an option too. So I'm going to go ahead and just hang tight here for another 5 minutes, but we just want to really thank you for your time and your attention to all these details. We thank you for taking care of our patients and for advocating for them and just all that you do. We know it's not an easy job, but we appreciate you guys taking care of their daily needs while they're at school. So like I said, we'll hang tight for another 5 minutes and then we will go ahead and end this webinar. So thank you again. Yeah, that's a great question, Julie. So let me just click off of this. So the American Diabetes Association, if you go on their website, they have some sample 504 documents that are fantastic. They've got recommendations on things that can be added to school care plans. We've got a document as well. Anna, will you write down and I can send that out to everybody? We've got a tips and tricks for the classroom that was created by one of our nurses, just of recommendations of things that can be added. But like I said, the American Diabetes Association does have some sample ones, and then they've got some different questions that can be asked for things that can be added. And then we've got little blurbs throughout our school care plan of things that you can also discuss. One thing I actually did not mention that I will say is that school excuse requests have changed as well for this year. I'm sorry, crazy that I forgot that. But it was explained to the parents last year, and it has been really reiterated this year that they can get school excuses that are from Lebonheur for encounters that they're on any Methodist property. So if they're in an emergency room or in the hospital or in an appointment, labs, education, anything of that nature, they will get a Lebonheur school excuse from us. If they're anywhere else, they may or may not get one, but they can request those from us. It's the parent's responsibility to get those school excuses over to you guys. But if they are, if a parent is keeping a child home, then they're going to have to write their own note for that. I'm not sure if there's any DeSoto County school nurses on here, but I know you guys have a form that addresses absences within the 504. And so that's a form that we get a lot and we fill out, and we've got recommendations on that. We've also got a letter that we can send that we've created. There's quite a few articles out there about children with chronic illnesses, and there's two in particular about children with diabetes, and that they do miss more school on average than normal children without diabetes, not normal children, but children without chronic illnesses, without diabetes. And so our recommendation in general, if we get one of those DeSoto County forms addressing school excuses or just in general, is that a patient may need up to 10 additional absences on top of like clinic appointments. So if absences is something that you guys are wanting to address in the 504 plan, then you can either send us a form or you can ask the parent to request that letter from us that outlines our recommendations that can be addressed in the 504. Someone asked, when a student is below 70 and is close to lunchtime, say 15 minutes or so, we have to treat it. And then once the student is stable after 15 minutes, then they go to lunch, but we still give insulin for the nutrition dose. That is a fantastic question. So yes, so you have to treat their low blood sugar before they have their meal. So you want it above 70 before they eat, and then you would dose their blood sugar off of a blood sugar of 70 or whatever the blood sugar was prior to that. So if their blood sugar is 68 and it's 20 minutes until lunch, or even 30 or 40 minutes, then you're not going to give that correction dose at that time. You're always dosing off of the very first blood sugar. So that first blood sugar was less than 70. But yes, you treat it, you get it above 70, and then you're going to give the insulin for just the carbs. You're not going to subtract anything from that carb amount. You also aren't going to just say, oh, you're good to go, just go eat your lunch and we won't do anything about it. So that's a fantastic question. Something to keep in mind too, that you probably run into as school nurses, is maybe that the parents do something different maybe they're not doing things correctly at home. And so when they come to school, they want to do those incorrect things or odd things. So you kind of have to be like, no, this is what your orders say. This is what we have to go by. And if the parents have questions about that, then they can reach out to us and we can go over that. One other thing is, if you guys are running into issues with parents and schools and with our orders and just different things, you can always contact me and we can try to triage as best as possible. We're going to be going through the parent now primarily, but if there is something that has reached a level of just a lot of confusion, then we may need to have what's called a care conference where we bring everyone to the table. And so that's something that we can potentially schedule and arrange in those kind of circumstances. Great question. Well, if there's nothing else, then we'll go ahead and jump off for now. But again, you can send me an email if you think of something along the way, or if you're watching this as a recording and at a later time and you've got a question, then you definitely can send me an email. And I'm happy to help in whatever way I can. I think the biggest thing that we just want everyone to know is we really do want to foster positive relationships all the way around with both the parents and the schools. And we just want to make sure that we're all on the same page. So I know that us having a lot of these forms and school care plans going through the patients is an extra step, but we're really hoping that it just brings everyone to the same page, so that we can get everything just crystal clear for the parents. But anyways, we appreciate you guys, and we're going to go ahead and hop off. I hope you have a great rest of your week and back to school season.